So hello, welcome everybody to the kickoff meeting of the AFB-STEP meeting here in Amsterdam. And I have the pleasure to have Renate Schnabel from the UKE in Hamburg with me for this interview. Hello Renate, thanks for being here.
Yeah, it's a pleasure to be here.
So can you introduce yourself real quick and delineate a little bit what your role in this entire consortium will be?
I'm an outsider, I'm an interventional cardiologist, but as many of you know, my research is on early detection and atrial fibrillation screening. That means low burden atrial fibrillation, and this is exactly where this fits in, and this is why I'm here in this consortium. And my specific role is as a work package leader, together with a large group of experts, that we look into the association of atrial fibrillation burden across a broad range of outcomes, not only stroke, but also cognitive decline, dementia, heart failure, cardiovascular mortality, etc. In addition, an important point in our work package is to work together with the patient forum and to define PROMs, patient-related outcome measures, in relation to atrial fibrillation burden, and to identify PREMs, patient-related experience measures, when taking atrial fibrillation burden measurements. And I think this is something really new, and we have started discussions on that, and I'm looking forward to the results that we will collate here.
What do you think are the most challenges that you will be facing in trying to put these data together to try to make it comparable on the one side, but then also on the other side to try to find a correlation with outcomes that you may have in your data sets?
Fortunately, we are supported by the other work packages. We really heavily depend on the data harmonization work package, on the statistical experience, and also on the definition of atrial fibrillation burden and how we can extract atrial fibrillation burden quantification measures from the other studies. What we have at hand are these huge studies, very heterogeneous, and this is a challenge to really combine them, find already existing patient-related outcome measures that we can use, harmonize them, and then associate them with the outcomes in an adequate fashion.
When we're facing especially information that we're sharing with general practitioners or cardiologists, we are obviously posing more questions than answers meanwhile. And what do you think is the major strengths of this whole consortium in terms of trying to answer these questions, in terms of like how often is AF recurring and what is the outcome related to that?
The strength, of course, is the huge and broad experience that people bring in here from researchers who have been looking into atrial fibrillation burden quantification for 10 years when nobody talked about it. We only recently have tried to define atrial fibrillation burden. We still don't know how to quantify it adequately, in particular in a clinical context. But we have clinicians here, we have experienced device people here. We have many industry partners, from wearables, intermittent monitoring to implantable device industry partners with also a huge interest in research. We have the patients here. We have many junior researchers who are really engaged in this project. And most importantly, I think everybody is very dedicated and ambitious. And so I think over the 4 years of the project, we will move this field really much forward, and we will have some answers to your questions.
Yeah, I guess so as well. Very looking forward to that as well. In terms of AF screening, I mean, there have been a lot of engagements being done to try to also epidemiologically try to find out which patients to screen and which not. I mean, this whole project is not primarily focusing on screening, but do you think from the data that we're gathering that there might be a new chance, or this might shed a new light on the aspect of AF screening? Do you think from this data we may be able to identify patient groups in whom we think that screening might be worthwhile, and it's just a selection problem that we had prior?
Yeah, and indeed, for me, it's also the understanding of the relevance of atrial fibrillation burden. To date, it has been AF, yes or no, and once we detect atrial fibrillation, we do a treatment, or anticoagulation, ablation, etc. But I think we need a more nuanced phenotype, and we need to tailor treatment accordingly. And if I may be provocative, maybe withhold treatment also in very low atrial fibrillation burden. And this is the setting where we kick in with screening. And what we have learned so far is that we do a continuous screening in asymptomatic individuals, and we find short episodes, very low atrial fibrillation burden, and anticoagulate them, we have limited benefit and more bleeding that we see. And therefore, it would be very important, and this can also be done as in this consortium in patients with atrial fibrillation, with known atrial fibrillation, to see how much atrial fibrillation burden we need to treat, for example, oral anticoagulation or ablation, and in how far very short bursts of atrial fibrillation are relevant at all, and maybe we do not need to treat by oral anticoagulation. And I think this understanding we can transfer to the screening setting, the very low burden atrial fibrillation setting.
So I'm hearing that we're also not only defining like the higher end of risk and AF burden, but it's also important to focus on the lower end, maybe define AF burden cutoffs where treatment can be postponed, or surveillance is one of the strategies. Is this something where you think patients could also benefit from, and how is this reflected in the work, in your work package?
Indeed, we will see if we have all this more or less continuous data on atrial fibrillation, and we'll define atrial fibrillation as a continuous variable and as potential thresholds. We will see whether we have an association with stroke, with cognitive decline, with heart failure. And if there is no association, then possibly this is a very low risk group who we will, of course, monitor further and manage their risk factors. Most of them have risk factors like the classical hypertension, diabetes, obesity. We need to manage those, but we can go on probably with the treatment of atrial fibrillation, withholding treatment for atrial fibrillation itself.
Something that patients would also very much benefit from, I guess.
Of course, because we do not want over-treatment, only because we have a short episode of atrial fibrillation.
Absolutely. So there are really many things to learn from this consortium with all these different stakeholders. And I'm really surprised that there are so many different parts being involved in atrial fibrillation are taking part of this. So on the top of your head, like besides what we just discussed, is there anything else that you would like to highlight from this consortium, or your expectation within the next 4 years that we're working together?
Yes, so far I've really been impressed by the expertise that is here, wonderful discussions, very vibrant group, and I'm very much looking forward to working together with them over the next 4 years, and I think we can move the field forward.
Thank you very much for the time you were taking to giving us this interview and these insights.
It has been a pleasure. Thank you, Daniel.